Good morning, everyone. I'm Tracy Lustig. I'm one of the study co-directors for the Committee on the Quality of Care in Nursing Homes. Along with Lori Gregg, I'd like to welcome everyone to this open session. The task being undertaken by this committee of the National Academies of Sciences, Engineering, and Medicine is to examine how our nation delivers, finances, regulates, and measures the quality of care in nursing homes. The committee's full official statement of task can be found on the project website, www.nationalacademies.org/nursing-homes. We want to thank, of course, the sponsors for this study, the John A. Hartford Foundation, Commonwealth Fund, the Fan Fox and Leslie R. Samuels Foundation, the Sephardic Foundation on Aging, and Jewish Healthcare Foundation. I'd like to note the committee members who are listed on the screen. We don't have time for each committee to introduce themselves, but as always, you can find the committee members' names and bios on our website as well. So I'd like to remind everyone that this is an information gathering session. We ask everyone here today to be mindful of the fact that the committee has made no conclusions, and it would be a mistake for anyone to leave here today thinking otherwise. Comments made by individuals, including members of the committee, should not be interpreted as positions of the committee or of the academies. In addition, the committee members typically ask probing questions in these information gathering sessions that may not be indicative of their personal views. We are also, as a reminder, inviting residents, family members, and nursing home staff to submit their stories and experiences to us. And you can find the link again on our website. Today's webinar will be recorded and it will be archived at the links shown on the screen. Again, you can also find through our project page. I want to note again, this is an open on the record session. Individuals from the public have been invited to attend as observers, but we will not be entertaining questions from the public. Please do note, however, that anyone at any time can submit testimony or other materials to the committee. These documents will be placed into the committee's public access file, and you can submit this information again through the project website. Today's webinar will explore a variety of perspectives. We have given each speaker only about 10 to 15 minutes for remarks, and we kindly ask speakers to be respectful of this time limit so that we can reserve the bulk of the time for questions with the committee members. So all of the speakers who've been invited today have bios online as well. So we want to welcome them all, and I'll just introduce everyone who will be joining us today. We have Wendy Boren and Nikki Martin from QITMO, the Quality Improvement Program for Missouri, Scott Bruner and Lacey Hunter from the Kansas Department for Aging and Disability Services, Tom Betlock from Spire Healthcare Strategies, and Barbara Coulter Edwards from BCE Health Policy. And so I'd like to turn it over to Wendy and Nikki to get us started.
Hi, good morning, everyone. Thank you for the opportunity to speak to the committee today. It is our pleasure to provide information on the Quality Improvement Program for Missouri, which is also known as QITMO. Next slide, please. Established in 1999, QITMO was cooperative service between the University of Missouri Sinclair School of Nursing and the Missouri Department of Health and Senior Services. It is supported by the department as part of an annual award to provide training and technical assistance to Missouri skilled nursing facilities. The QITMO program was first of its kind in the country. QITMO offers confidential, on-site, and virtual consultation and technical assistance at no cost to facilities. The predominant aim of QITMO is to improve the quality care received by Missouri nursing home residents. Next slide, please. Program delivery is typically accomplished by direct contact with skilled nursing facilities by our 5 clinical nurse educators and 3 Missouri licensed nursing home administrators. With a combined 438 years nursing and long-term care administration experience, QITMO staff all have extensive long-term care backgrounds as staff nurses, MDS coordinators, directors of nursing, certified nursing assistants, and administrators. Missouri is divided into 7 Department of Health Senior Services survey regions, and each team member has a region that closely aligns with those 7 Department of Health and Senior Services regions. Next slide, please. So as you're very well aware, 2020 threw the entire world a curveball, and we quickly adjusted our approach to providing services. Like so many others, we went virtual. We were in uncharted waters for a team that was used to being hands-on, boots on the ground, consultants and educators. There were many phone calls asking when we could return to on-site visits. Thankfully, in April of 2021, the doors opened back up for us, and we have returned to our road warrior status, trying to fulfill visit requests as quickly as we can. We facilitate our goal by providing clinical and administrative support to Missouri's skilled nursing home providers. These services we provide are individualized for each home and each situation. Quitmo tailors the service to a home's current need. Homes reach out to us and ask for assistance with such topics as RAI process and MDS completion, quality measures, 5-star rating, understanding CASPER reports, and the QAPI. We recognize that while regulations and standards of care are the same for skilled nursing providers, each home is unique, and the approach to providing our services is based on that uniqueness. In 2019, 1,293 on-site visits were made, reaching approximately 70% of our providers. Our weekly administrator and director of nursing virtual support groups, which began in April of 2020, were very well attended, with over 23,000 attendees. The support groups focused on the public health emergency in order to dissect and interpret information and the overwhelming amount of information that was being provided by both federal and state agencies, and relay the information in a way that was more easily understandable. Next slide, please. Our website is where we keep our collection of our resources, our upcoming events and webinars, research, and our contact information. We noticed activity on our website trending up beginning in mid-2020 and continued through the first quarter of 2021, with 877 new users, and much to our surprise, from other countries such as Canada, the UK, France, India, Ireland, and the Philippines. And now I'm going to turn it over to Wendy to talk a little more about what it is we do when we visit our homes. Next slide, please.
Well, good morning, and thank you for having us. So just a little bit about what we do. Our on-site mock surveys, a lot of the nurses that come into long-term care are from the hospital setting. So converting from a JACO survey to a state survey is quite a new process. So we do our best to go in with all the expectations of the regulations that are related specifically to a state inspection. So we spend quite a lot of time on that. And then after the survey, we also help them with their plan of correction. Of course, as Nikki said, our core work is on site. We do clinical, administrative, and environmental consultation, and that goes everything from like wound assessments, a lot of dementia care, education, behavioral health, of course, infection control. That's our big go-to right now. Administration-wise, we look at life safety elements, HR. Our coaches work a ton with policies and procedures, emergency management. And then, of course, we do a lot with our documentation. So documentation audits, we do virtually and on site. And those are mostly focused on the Medicare reimbursement, the PDPM, and specific issues related to the quality assurance program. So that includes things like the antipsychotic reductions and GDRs. Again, wound care, if someone's gotten cited for a wound issue, we will go through and thoroughly check the documentation. But at the end of the day, our documentation audits really encourage the nurses to tell the whole story. So I will say this is most prevalent with the COVID documentation. We've done a lot of that the last couple of months. And I can tell you, reading that whole story is very humbling and very sad, but definitely shows, you know, our nurses what we expect of them and what would be expected when CMS does an audit. Also, we do a ton of MDS training. So most of our nurses are RAC certified and excellent at teaching MDS. For any nurse on the floor, MDS is a whole different animal. That's not something that nurses are trained to do in nursing school, including myself. So understanding that the rules and the timelines associated with MDS are really important, because that is where a good part of the facility's paycheck is going to come from. So there's a whole different element to understanding the coding. And then of course, getting on task with what needs to be done, where and when, and the documentation to back it up. Next slide, please. We also do a lot with the ICAR program and the infection preventionist training and audits. So for those of you who are not aware of the ICAR, it's the Infection Control Assessment Response. We've begun doing ICARs in late December and early January virtually. We've done about 150 so far. We have a specific ICAR team that helps with the assisted livings and the skilled facilities. Of course, our Equipmo team also handles the skilled facilities, as we've already got the connections there. We work on QAPI projects, the quality assurance and improvement projects. And this can be anything that the home feels the need to work on, usually recognized in their quality assurance meetings. For example, one of them that I worked on was a fall collaboration, studying the falls in 3 different nursing homes, and then working with a geriatric practitioner from St. Louis University on how we could reduce those falls in those homes. And it was very, very beneficial to those 3 homes. Quality measures. This gives the nursing homes a picture of what's in their home, who they admit, what type of residents they are keeping in their building, and where improvements can be made. So that can be anything from, again, reduction of antipsychotics, wound care, or falls, just a variety of areas where they need to see improvement. And then lastly, we also do a ton of leadership training. And just recently, Libby and Nikki are working on a new a new administrator training for the new administrators within the state. With everything that's gone on, of course, we've had a ton of turnover, and administrators don't know what to do. It's a new expectation out there. Another nurse and I have also done new DON training, and it's a whole different expectation of life out there in long-term care. So spending that one-on-one time, hopefully mostly in person, we've done some virtual as well, letting them know that they have support, letting them know that they can answer questions, that they have someone to reach out to is really, really vital. Next slide, please. And then lastly, we have the program we do because of our partnerships. And that includes our state healthcare organizations like the Missouri Healthcare Association, Missouri League for Nursing, the Nursing Home Administrators and Leading Age. And we present for them very often throughout the year. We also are involved with Missouri's Telehealth Echo program, where we can serve as committee members and as consultants. And then we work with local community and county emergency and management. And this is an area that kind of hit a new peak this year, as I'm sure you can imagine. By harboring those connections and networking, we were able to get homes that needed PPE immediately, things that day, that week, things for their staff. And that wouldn't have happened without making those connections to include the nursing homes in the long-term picture of emergency management. And then, of course, lastly, we always collaborate with DHSS. Of course, as Nikki said, especially during the pandemic, that became extremely important. Next slide. So it is our recommendation that every state have a QIPMO program staffed with highly educated nurses, administrators, and other interdisciplinary staff, and sponsored by a university school of nursing within the state to facilitate credibility and relationship building. This last year has really taught me more than anything about our position in the community of long-term care. It truly takes a village, and the QIPMO family, the QIPMO faculty, the networking and outreach we can do, that has shown that any state who has this program will be able to provide the support and leadership for the long-term care homes that desperately need it right now and desperately need all of the support and understanding that they can get. So thank you very much. And feel free to check us out.
Thank you so much. We will now turn it over to Scott Bruner and Lacey Hunter.
Great. Thanks, Caitlin, and thanks to the committee for the invitation to share some perspectives with you today. My name is Scott Bruner. I'm the Deputy Secretary for the Kansas Department for Aging and Disability Services. I work with our state hospitals for people with mental illness and people with IDD, but as well as our survey and certification group. So I'm happy to kick off our presentation providing responses to some questions we got from the staff about the state survey perspective, things that are working, things that create variation among states in the survey process, and then a few recommendations at the end. Caitlin, you can go to and I'll let Lacey introduce herself when she starts off, but I did want to start with just a little bit of context about Kansas to set the framework. We've got 326 certified nursing facilities across the state that are subject to the survey process. And we conduct those surveys with 54, we have 54 authorized positions for state surveyors. 37 of them are currently filled, and we've got 17 vacancies, a good chunk of those in the kind of northeast corner of the state, but we've got some vacant positions across the state as well. Our position is that we only employ registered nurses to be surveyors, which is a little different than some other states and does make the competition for nursing staff to do this kind of work. We're part of that larger healthcare environment, recruiting nurses in the world. Some things that make that difficult are the amount that we can pay nurses to do this work. We included on the slide there our average surveyor salary once they become certified to do the work is $53,000. So that's you could make more money doing other kinds of nursing, particularly in the last 15 months with the pandemic. And then the last point that we wanted to try to capture was just the rural nature of Kansas. We've got urban areas, we've got a lot of rural communities, and that drives the size of the nursing homes that operate in our state. We thought we'd capture that by showing you the average. So it's an average of 62 beds, but is the average size. But there's a lot of variety between around that average. The staff did ask us to provide some perspectives from the state perspective, and so we're presenting Kansas's perspective. I don't know how typical that is. We do work closely with our regional CMS office and the 4 other states in our CMS region. So we tried to think a little bit about their perspectives as well, but I did want to make sure we reflect this as Kansas's experience, and we'll speak about it from that perspective. But to do that, I'd invite Lacey Hunter. She's our commissioner for survey and certification. It's her team that does this work, and she's certainly the expert, more so than me. So I'll ask her to move on to the next slide, and then I'll come back at the end with some of our recommendations and observations at the end of the presentation. Thanks.
Good morning. Thank you for having me. As Scott had mentioned, my name is Lacey Hunter. I'm the Commissioner of Survey and Certification. I oversee the long-term care survey process for the state of Kansas. So I think one of the first delineations I will make is that in the state of Kansas, we split our certified work up into long-term care and non-long-term care. Our agency oversees the long-term care portion. So much of what we're saying is going to reflect only that. So one of the things that we were kind of tasked with kind of providing feedback with is how the federal guidelines and how they create the survey process and how they create that framework. And so how that happens is you have the state operations manual, you have the long-term care survey process guide, and then you have the Aspen ASCQ, which is so Aspen is the automated survey process environment, and then ASCQ is Aspen Survey Explorer, which is the computer program that is used by our survey staff. So when you're looking at doing the long-term care survey process, it is very structured and it is very outlined when you're looking at those 3 different guidances. And we do follow that very closely. So when you're looking at our survey, it should follow what you're seeing in those readings. And that kind of includes a typical work week for us, which is a 10-hour work week, Monday through Thursday typically, but we do have those off-hours surveys and or those complaint or abbreviated surveys where we're entering depending on the nature of the survey during a different shift or a different time or day. But typically, we're looking for that recertification survey at 1 day for initial pooling. We're then looking to go into 3 days of investigation and then 1 day to write those findings. And when we're doing that, we're looking at then at those 4 days on site for that 4-hour work for that 4-day work week, with then that work from home type situation with the writing up for that portion of the survey. The thing we were then asked to kind of provide some feedback on was, how that varies and how that's different from what you do see in those writings and in those reference guides. And so in Kansas, kind of the things that we see that vary and that you're not going to necessarily see in that guidance is the amount of time that's spent in each of those survey areas. While each survey area is very much outlined and included in those guidelines, the amount of time and the amount of investigation that's spent in each of those areas can vary from facility to facility and from survey to survey. So it very much then varies from state to state. In Kansas, some of those big variations are based on the facility size and where that facility is located, whether it be out in kind of our rural western part of the state. The other thing that we are seeing, I think even more so now that we're really ramping up our survey efforts, is the number of issues and the number of complaints that we attach to a survey. With having our survey work restricted and kind of titrated back into full swing, we have definitely seen the struggles with the number of issues and the number of complaints that we are putting onto our surveys in order to try and create that backlog gap and bringing it back up into the current. The last thing that we have noticed is the feedback that you're getting from facilities. So based off of your staff and resident interviews, family interviews, vendor interviews, depending on the kind of feedback and the amount of feedback you're getting can really vary how long you're spending on that different survey task. Next slide, please. Okay, so then the last thing we were going to talk about on the variations is how we vary from state to state. And as Scott had mentioned, we do try to work very closely with the states in our region. And so this is kind of a list of things that we were able to come up with that we vary from within our region. And we do believe that we kind of vary from, nationally as well. So that starts with the training process. And that in our training process could be varied from any state's training process. We do have a pretty lengthy training process. Our training process, we did when the long-term care survey process started in 2017, we started with giving a new survey hiree, I guess you could say, a year to complete the long-term care survey process training and get certified. Since then, we have tried to kind of push that up to around 8 months. We do still allow within the position description, though, for up to 12 months. That, from what I can tell from our region, is a little bit lengthier than some of the other states in our area. The next variation that you can see from state to state is the regulation state of operations manual and appendix interpretations. And that can vary just by human nature. So our different trainers, the different preceptor that you could be assigned for your training of your survey process training. And then lastly, the other thing that we noticed is that we in the state of Kansas, we were early to the QIS process prior to the long-term care survey process being implemented by CMS in 2017. The state of Kansas was a pilot state for the QIS process, which just kind of a little background there. So prior to the long-term care survey process, you had the opportunity to use the QIS process or the traditional process. The traditional process was very paper-based. The QIS was much more automated through the computer. So with us being a QIS pilot state, when the long-term care survey process was implemented in 2017, most all of our staff were very comfortable and very knowledgeable of doing the survey process on a computer as opposed to doing that traditional process, which some of our regional partners who were on that traditional process have described kind of how much longer it took them to implement and truly be able to utilize that long-term care survey process. That's all I have, so I'm going to turn it back over to Scott now. Thank you for having me today.
Thanks, Lacey. So we did reflect a little bit, as Lacey was talking about, on the variations between states, and then kind of the last couple of questions were about limitations that we observed with the state survey process, and then some of the recommendations that we would make. So in terms of limitations, kind of ideas we've already talked a little bit about. The survey level for surveyors and competing for qualified staff, that's a challenge for a state like Kansas and probably other states. It was a problem before the pandemic, and certainly was a problem during. It's just that it's a different kind of work, and we've got to be able to recruit people to do that, particularly registered nurses, since that's our requirement. Access to electronic equipment and technology to be able to do this work remotely. We found that during the pandemic that our surveyors were actually in pretty good shape because they already did this work electronically primarily and away from an office. But we did have to supplement that with mobile access and some other hotspots, things like that, so they could do all of the work remotely as opposed to having a home base to come back to. And then finally, the limitation of the incorporating the electronic plans of care and just kind of streamlining the process to make it more electronic. That's a limit if you don't have the technology, the people, the training. And think Kansas was a little bit in a better position because we were a pilot state and could try some of those things out early on. But in terms of wish list or recommendations that we would make to change the survey process with the goals of resident satisfaction, health and safety in mind, as well as effectiveness of the survey process. So that as we thought about it, that we came up with these kind of 4 points. We think a faster timeline for information and technology rollout from CMS, particularly during the pandemic, but even before that, we'd get chatter from the network working with our regional office of policy change was coming or some pandemic related guidance was going to come, and it would take weeks or months for that to finally roll out in final form. Getting that information faster helps us be more responsive as well as CMS. So improving that timeline. Enhanced federal match for state survey and certification workforce. It's already an enhanced federal match for these activities for the state, but maybe looking at even going further, going above the 75% federal match to maybe using the IT match of 90%, maybe for just the technology parts or even for the staffing. That's a tool that CMS has available. They'd have to elect to use it and probably get some congressional help as well. Assistance from CMS with backlog on the recertification and complaint work. We did find that over the course of the pandemic, if we got behind or CMS was willing to come in and help complete some of the infection control surveys, and that really did help us meet a lot of the targets that we had to in terms of performance standard and timeliness. Having that available from CMS or from the federal level and other times when we get behind or need to do recertifications would be great, with CMS providing kind of a reserve workforce for that activity. And then finally, an issue that comes up a lot in Kansas and I'm sure in other states about direct care workforce. I mean, a lot of the quality control and safety aspects in nursing facilities ties directly to how many people are working on the floor providing care. We've got real problems in Kansas recruiting, retaining, and maintaining the workforce of direct care, in addition to clinical staff, nursing, and others. But I think it's reached the level of a national need for really addressing quality, consistency, recruiting, making that a viable progressive kind of job where working in direct care and long-term care is an important part of the healthcare workforce as well as the long-term care workforce. And national leadership in that and direction would certainly escalate efforts that are going on in states, but also just give it the kind of oomph it needs to really take off, and the federal funding wouldn't hurt as well. So those were our observations. Again, we appreciate the opportunity to present and look forward to your questions. And again, maybe just as the final point, this is the Kansas experience and perspective. Other states could be different. We're not claiming to be a model for other states, but we're happy to share our observations from the center of the country, and look forward to your questions.
Thank you so much. We will now turn it over to Tom Betlock.
Thank you. Great to be with everybody today. Thank you for the opportunity. Tom Betlock. I served as the Medicaid director in the state of Arizona for almost a decade. Prior to that, I was the deputy director as well. I've been asked by the staff to speak to a lot of the rate setting issues that occur for nursing facility payments from the Medicaid program, questions around adequacy, questions around the use of cost data, question on the role of supplemental payments. So as you can imagine, rates are really a combination of science, art, and politics, and putting that all together and seeing how that plays out within each individual state. So states have a variety of approaches in terms of how they look at nursing facility payments, and can vary just starting with the delivery system and the use of managed long-term services and supports versus fee-for-service. I'll speak a little bit more about managed care in a few minutes. And states obviously can have a lot of complexity in their nursing facility rates. So I think of one state, for example, just on their fee-for-service rates for nursing facility, they have 45 pages of their calculations delineated in rules. So anytime there's going to be a change in terms of that methodology, they need to go in, they need to promulgate rules. And oftentimes for states, that can be a year or more process. Some states do annual rates with an update. Some states do a quarterly rate that gets reconciled multiple times based on cost studies. Some states have base rates, and then they layer on upper payment limit payments, which are calculations made to determine sort of a Medicare-like methodology. And then some states also add in quality incentive payments that are made on top of either a base rate or an upper payment limit rate. And I think what's interesting is, as I was thinking about the discussion for today, sometimes we have made these rates so complex and the discussions and the calculations around them that oftentimes it seems to me energy is diverted from other more important issues like quality, like initiatives around transitions of care and other things like that. So in many states, there's a lot of energy, a lot of discussion that goes into nursing facility rates. In terms of adequacy, there's a variety of different approaches to look at adequacy. And so the example I'll give you is Arizona. It's the one I'm most familiar with. But in terms of adequacy, we start by using the cost data reports and really establishing base rates that are predicated on that. That's not done on an annual basis. There's a rebase every 3 to 5 years, depending upon all the different things that may be going on within the program. The rates are then updated annually to reflect cost increases. So while I was there, the rates were never adjusted downward for cost decreases, but obviously we did have to deal with the Great Recession. So we had to come up with ways to help try and supplement so that we didn't have to cut rates. There were special adjustments made for labor costs. For example, in Arizona, there was an initiative to increase minimum wage. It's now at $13 roughly. And so those adjustments had to be built in for nursing facilities for the staff associated with payments in which there would be increases. There were adjustments for increased acuity in terms of the population being served by nursing facilities. There were adjustments made to reflect the higher costs that managed care plans may be paying for specialty rates and other things like that for populations. There were adjustments made for the political changes made by the legislature in which rates would get adjusted. And then there were partnerships that were done with nursing facilities to look at opportunities to adjust payments, oftentimes around supplemental payments and oftentimes around looking at ways to look at things like an assessment, which is an assessment on nursing facility bed days, to be able to bring in some additional federal financing. States often use benchmarks as well. So for example, in Arizona, we looked at using benchmark data to be able to compare ourselves to other Western states to see how we were doing in terms of overall rates. And then we'd also look at other data that we felt were important in terms of being able to analyze the overall health of our nursing facility industry. So we'd look at ways to try and track profitability of the overall nursing facilities. We'd be looking at information on closures. We'd be looking at facilities that might have excessive number of empty beds. And so being able to just get both the combination of data from the nursing facility industry to see how the industry was doing overall financially, as well as quality data, and then get some additional information to better understand how the overall reimbursement rates were doing in terms of adequacy to support the nursing facility infrastructure that was necessary for the members in Arizona. I was also asked the question by staff in terms of what are some of the main challenges in raising rates. So as we would identify potentially a higher cost within our nursing facilities, obviously in Medicaid, there's a number of competing priorities that need to be balanced, right? So the first is just the overall costs of the program due to coverage. Medicaid now costs more because there's over 80 million individuals enrolled in the Medicaid program. And so as a result of this increased overall coverage, there's higher costs for states for that as well. Another competing priority were new services. So for example, in Arizona, our legislature added dental benefits for the adult population. And obviously that comes at a cost, and those dollars are going then to add on new services versus being there to be able to be used for nursing facilities. And then there's just other competing costs within the overall healthcare ecosystem, right? So there's special initiatives that might be occurring within the Medicaid program in terms of increasing access for children with autism or individuals with serious mental illness or other issues that might be going on. And then there's just underlying cost drivers. For example, like medication, the year that Sovaldi came to market, states experienced some pretty significant increased costs. So being able to balance all of that and all of those competing priorities in terms of looking at what resources are available for things like nursing facility rates. I was asked by the staff to think about and look at the idea of having a standard minimum rate similar to the Boren Amendment for nursing facilities. And so I think part of the challenge in that is, while it may seem like something that is a policy solution, there's a lot of underlying operational issues to it that just, I think, becomes very challenging. So the first is just to be able to compare costs. How do you compare costs of running nursing facilities in Kansas to Phoenix to New York City? How do you compare states that have very different mixes in terms of their nursing facility population? So if you compare a state like Arizona, in which 25% of the long-term care population is in a nursing facility or institutional placement, and compare that to a state like Indiana that has a much higher percentage of its population in a nursing facility, then the mix of that population looks completely different, and the costs associated with supporting that population from just a base rate perspective look completely different. And so I think that becomes incredibly challenging to think about from the perspective of, let's establish a federal minimum floor. And then how do you compare states that might have completely different Medicare utilization in terms of how it impacts the overall need for Medicaid to support the nursing facility infrastructure? I mean, when you look at states that might have high churn of nursing facility members moving to a hospital back to a nursing facility in which Medicare is making those much higher payments for that 90-day post-inpatient stay, that obviously has an impact in terms of revenues for nursing facilities. But for states that might be doing a better job in terms of working with nursing facilities and having less inpatient utilization, there's less Medicare revenue, and Medicaid might need to be higher to support that loss of increased Medicare revenue. So there are so many different complex moving pieces in terms of thinking about this. I was asked the question by staff in terms of, should the federal government pay 100% of nursing facility costs? And I think that that's incredibly challenging. Anytime, if you're going to build this on the Medicaid chassis, if you look at 100% federal financing for something or a very enhanced rate, I think it distorts decision-making in terms of, well, why would I put anybody in home and community-based services if I'm going to have the federal government pay for the nursing facility costs? Yet we all know that people prefer being in their home or in the community, and it's a much lower cost in terms of the overall cost of the healthcare system. So I think there would be tremendous misaligned incentives if the federal government were to consider providing 100% cost for nursing facilities to the states. As I mentioned earlier, states use a variety of different financing mechanisms for nursing facilities, including supplemental payments, assessments on nursing facilities, and oftentimes those really aren't tied to, I think, some specific quality initiatives, because in many instances, it's just a mechanism by which states are trying to get nursing facilities additional resources. And so the bar oftentimes can be set too low in terms of what that looks like. In terms of the use of managed long-term services and supports and rates, I think you have to recognize that for most states, managed care for this population is less than 10 years old. And I think as a result of that, states wanted to make sure there were certain guardrails in place. And in many instances, states did that by going ahead and creating an infrastructure and saying you need to pay a minimum rate of this. And so in many instances, or providers like nursing facilities have been somewhat protected with the rollout in terms of the use of managed care. And I think it's important as we talk about managed care just to reflect on the role managed care plays in managed long-term services and supports. And in Arizona, we have had it in place for over 30 years. And it really becomes the primary platform in which states can create a single accountable organization to better serve this population. And when you think about the nursing facility population, we know that a large percentage of that population are dual eligible members. And so they're stuck between these two very large programs that historically have done a lousy job of care coordination. It's incredibly fragmented. And oftentimes we've resulted on the member or the family members having to negotiate and navigate these two large systems that have historically done a very poor job of care coordination. So if you were to ask me in terms of what's the most important recommendations to improve the quality of care in nursing facilities, is to look at the system design and how we've created this system where for the majority of people who are complex and require institutional level of care, they're dual eligible members. And we don't have a great way, unless you have a managed care organization, than which the members align getting both their Medicare and Medicaid services delivered. And we have third-party studies that validate the improved outcomes associated with that. So unless you have a platform by which you can organize care for dual eligible members, in many instances, if you don't have that, the care is fragmented, it's disjointed, and it lacks accountability, and there's lack of aligned incentives. So if we're really going to improve nursing facility care in this country and long-term care, because we really should look at it from a continuum perspective, not just at the site of nursing facility, then we need to address the disjointed care that's a result of the dual eligible structure in the United States.
Thank you so much. We will now turn it over to Barbara Edwards.
I also want to thank you for the invitation to address the Committee on Quality Care in Nursing Homes today. When I was Medicaid director for the state of Ohio, and it was 15 years ago, I didn't quite hit Tom's record, I think, of 10 years as a director. I was director for 8 years. I worked closely with the governor's office on a multi-year effort to enact nursing home reimbursement reforms, a real challenge in Ohio reimbursement because it's all in statute. So it all has to be negotiated through the legislature, and the nursing home industry is traditionally very powerful in that forum. One of the goals that we achieved was to include for the first time a specific incentive payment focused on quality of care. Now, this was baby steps by today's more evolved efforts. I'm very impressed with states like Missouri and Ohio that have these national and state level nursing home quality improvement programs in place. And when we were looking at this issue, it was before there were widely accepted quality measures for the industry. This was pre the STAR ratings by Medicare even. But it clearly signaled that Medicaid wanted to connect reimbursement to performance. And I still think that's a critical step if states are really going to be effective at getting change in the performance in the industry. The state of Ohio has further developed this strategy over time, taking advantage of new measures, taking advantage of the consumer satisfaction surveys that are available today for family and residents. But I do think it's still a challenge to make this as effective as it could be, because again, it's difficult to know how much money has to be tied to incentive payments to really have of an incentive for the industry to pay attention, and having to negotiate those standards through a legislative process also makes it difficult to push the industry, I think, very hard, particularly when there are a lot of other issues on the table. When I was director of Medicaid's Disabled and Elderly Health Programs Group at the Center for Medicare and Medicaid Services, my staff developed new federal policy regarding managed long-term services and supports. This was at a time immediately after the enactment of the Affordable Care Act, when a significant number of states were pursuing integrated models of care that included long-term services and supports, often as part of initiatives testing integrated service models for people who were dually eligible for both Medicaid and Medicare. Tom just underscored how important it is, if you're going to really get a handle on these issues, that this disjointed relationship between Medicare and Medicaid needs to be addressed. And nursing facility care is one of those places where we see some of the impact of having two payers and players in the system. The significant focus of the standards that the federal government developed under the Affordable Care Act implementation timeframe was more focused on assuring that managed care arrangements resulted in increased choice for consumers to access home and community-based service options, rather than a particular focus on measuring quality of care within nursing facilities or even at home and community-based service settings. The advocates at the time were deeply concerned that managed care plans, which really had not much experience with long-term care, would not understand the person-centered, non-medical model of long-term services and supports that Medicaid has been pursuing, and a concern that they might, in fact, default to default to nursing homes and working with that industry. And I want to underscore for the committee that when Medicaid does buy post-acute services from nursing facilities, just like Medicare does. But its more significant relationship with NIFs is for long-term services and supports for people who need ongoing assistance with personal care, ADLs, IADLs, in addition to nursing services. That means that for Medicaid, improving nursing home quality really needs to include a strong focus on long-term care, not just short-term recovery and rehabilitation after a hospital stay. And it also means that quality of life for residents, not just to focus on the outcomes of nursing and medical care, is also critical. National development of the CAHPS Consumer and Family Satisfaction Surveys has given states one set of important tools to begin to look at quality of life in both institutional and home and community-based settings of care. And that's a real improvement over what's been available in the past. And it's, I think, important that states and managed care plans take full advantage of those surveys. I anticipated correctly that Tom would do a really good job of covering some of the technical aspects that the committee was interested in, particularly regarding how states approach reimbursement. And so in the rest of my remarks prior to questions, I want to be a little aspirational in a couple of topics. I think one of the biggest stumbling blocks to improve quality in nursing facilities, and was mentioned by Scott Brunner earlier, is the underlying challenge of workforce shortages. Lots of research shows the link between higher staffing levels for nursing, RN, LPN, CNAs, and a higher quality of care for residents. There's also a lot of evidence that significant numbers of facilities fail to meet CMS's recommended levels of staffing. Advocates and researchers have recommendations that range from the need for more explicit national regulatory standards, setting a higher standard of nursing care, higher reimbursement to support higher wages for direct care staff, and a total retooling of the job for direct care workers, paying attention to wages and benefits, training, career ladders, quality of life, frankly, including safety, because workers in nursing facilities are often among the most injured in terms of workers' comp claims. This problem has been talked about for a long time with little focused or sustained attention. And in recent years, we've seen that many states have taken, for them, an unusual step of enacting targeted rate adjustments to NIFs and even to HCBS providers to provide increased wages for direct care workers. And in states that have done that, if they're using managed care for long-term care, they are requiring the plans to pass those increased wages along as well. But the growth in demand for care for long-term care continues to outstrip workability. And projections about the future of our labor market are not encouraging on this item. There may be serious structural imbalances between the relatively slow growth in the labor market compared to the rapidly developing demand for care, particularly with the baby boomers as they're aging into the old population that is most in need of long-term services and supports. So I would argue that a national effort with enhanced federal financing, whether it's grants, enhanced match, even performance bonuses for states as well as providers, is needed immediately to increase the impact of current efforts and to encourage further innovation by states and providers. A national response needs to include attention to immigration policy as one option that could actually increase the potential labor market, since immigrants are already a pretty significant part of current direct care workforce. Federal financing could also help increase the pace of investment in technology that might slow the increase in demand for direct care to something more manageable. And here's where I want to be aspirational, because what I think is really needed is a game changer to reduce the rate of growth and demand for long-term services and supports that's coming quickly. The biggest game changer would be a real treatment and prevention strategy for Alzheimer's and other dementias. I know there's a lot of attention being paid to this, but frankly, I don't feel as though the nation has really taken this on and declared war on Alzheimer's and dementia. In 2018, some form of dementia was reported as an underlying cause of death for 267,000 adults in the United States. As baby boomers age, the numbers of individuals with dementia is going to increase dramatically, and this is a driver of need for long-term services and supports. A cure and effective preventive strategy would dramatically change the growth in this demand and the need for ever more workers. Maybe this sounds unrealistic, but I've seen estimates that the US spent $18 to $23 billion on COVID research. In 2021, NIH expects to spend only $3 billion on Alzheimer's research. That represents a pretty increased investment of federal money in recent years, but it's surely wildly inadequate given the toll that dementia is going to place on our nation's seniors, their families, on the healthcare system, and on the taxpayer that's going to finance a lot of this care over the next 20 to 40 years. So that's my pipe dream. I have a more immediate recommendation, which is also difficult, but it's that we need to better recognize that family and advocate involvement is critical to quality, both on the rehabilitative and the long-term care sides of the business. Nursing homes provide services to individuals who are often at their most vulnerable. And while residents should always be encouraged to be involved and advocate, I lost you for a moment, to be involved and advocate for themselves and their care, many must rely on family and others to advocate on their behalf when they are in a nursing facility. Further, in reality, families often serve as staff extenders, providing daily activities, improving quality of life, improving attention to how residents are doing, and providing assistance, hands-on assistance with ADLs and IADLs. The single greatest horror of the COVID response, especially for individuals in long-term care, was losing access to family caregivers and other advocates. And given the already low levels of staffing in too many facilities, compounded by the fact that staff were also ill with COVID, this just seems like it was a nightmare, a crisis for all of us. While I understand why regulators and providers felt the need to exclude family from facilities during the crisis, we have to have alternatives to the strategy going forward. I think it's really important that we don't allow this to be part of any facility's long-term as a Medicaid director and in the Medicaid program is that just putting more money into the current system of NIF reimbursement just buys more of the same. not improved quality or innovative models of care. To get better or different, new money and even and old money combined needs to be tied to new outcomes. For Medicaid, my second point is that it won't be effective to address issues like staffing and funding and quality goals in only one part of the long-term services support system. Tom talked about how important it was to look at the whole healthcare system holistically if you want to really get good nursing home care. I think it's also important to recognize that for states, the majority of, in most states, are being served in home and community-based settings. Most of the money nationally is still going to nursing facilities, particularly for older adults and people with physical disabilities. But most of the people are in home and community-based settings. And as Tom pointed out, state-to-state experience can vary wildly. In some states, only 20% of spending is in nursing facilities. In others, it might be 80%. But what I'm pointing out is that directors are going to want to stay focused on the impact of their whole long-term care system, particularly strategies that might improve or staffing attention or quality attention only on one side of their long-term care system is going to cause them to kind of approach that with some caution, because they're going to be very concerned that they don't disadvantage home and community-based providers, for example, who are competing for that same workforce pool and who are in fact serving more individuals. So it's important to be able to think about these issues of quality and labor and measurement in a holistic way across the long-term services system for states. Thank you.
Thank you so much, Barbara, and all of the other speakers we've just heard from. I'll invite you all to turn your videos back on, and we will now go over to the open the discussion with the committee members. And for the committee, if you could raise your hand, and if you can't find the function on the bottom of your screen, as a reminder, you can press Alt and Y on your keyboard, and that will raise your hand. And it looks like we have Dr. Konecka up first.
Hi, everyone. And first of all, apologies to everyone for my technical difficulties at the outset that made me miss the introductions. My question is mostly for Tom Bedlock, although others may want to weigh in. I really appreciated your detailed discussion of the challenges and complexity of Medicaid rate setting. But one follow-up to that, one follow-up question is, you talked a lot about using the cost reports as part of that rate setting process and making sure that payments are adjusted to cover those costs. How do you think about costs in a structure where so many nursing homes engage in these related party transactions? Do you trust that cost report data to actually show you what the expenses are, or how do you get around that?
That's a great question, an incredible challenge, and certainly would ask for Barb to chime in as well as we discuss this topic. But I think every cost report comes with some grain of salt in terms of its true value in rate setting. So first of all, let's start with the premise that, cost-based reimbursement has misaligned incentives, because the more I increase my costs, the higher that you're going to pay. And the more that I might be doing my cost allocation methodology, the more that I can target certain payers in terms of how you may be looking at the overall cost report data. So I think cost report information is a proxy in terms of being able to get a gauge on where the cost might be. But I think everybody that is looking at cost-based data has to take that and presume that there are challenges associated with it. There's lag data. I think there's incomplete data. But at this point in time, it's the best information we have. It's become the policy go-to in terms of the expectations of the provider community and working with legislatures to be able to say you have some cost-based data in looking at this. But it's just one of, I think, multiple data points states need to be looking at in rate setting. Barb, what would you like to add?
Yeah, absolutely. I mean, the reality is that cost reports may be reflecting costs. They're not necessarily reflecting what costs ought to be. And that's particularly true if you've got a lot of self-dealing going on within the industry. Keep those costs down if they get to pass those costs on. particularly if, as a larger organization, there's other people profiting within that business relationship. It's all good. So not necessarily for the buyer, but it's all good for the provider. So I think that it's really important not to get too fixated on the cost reports, because there's an awful lot there that is a constructed cost that may not be reflecting what would represent true value in the system. One of the things that we learned, and I think many states learn, is that whenever you put together a reimbursement strategy, you have a strategy typically about where you're trying to go with it, and trying to build efficiencies into the system, trying to put the right kind of incentives in place. But the fact is, over time, smart providers are smart business people, and they get very good at maximizing revenue under whatever relationship you've created in that reimbursement methodology. So there could just be some value in changing things up from time to time. So at least people have to start over again and trying to figure out how to game the system. State-federal relationship has many of the same markers. So I think it's important not to get too fixated on it. When we did reform several years ago in Ohio, one of the things we were trying to do was to move away from a formula that was really a cost pass-through with annual, rebasing. It was just the more they could drive costs up, the more money they were going to get from the state. And that's why I say more money doesn't get you different. It gets you just more of the same. We tried to move toward more of a market established rate that would encourage providers to become more efficient because their competitors were able to do business at that rate and do it well. So again, did that work? It helped. But over time, I'm sure people have again learned how to maximize every opportunity to bring new revenue in underneath the reform formula that we put in place. So I agree. I think cost basis is important to understand, but I think it should not be the sole driver of reimbursement. You really want to pay for what you want out of the system, not for what the providers are putting into the system.
Yeah, and the challenging thing is, I mentioned the state that had 45 pages in terms of their cost-based reimbursement structure that had multiple reconciliations. And not once in that 45 pages is there any mention of quality or what value is. It's just simply, mathematical calculations based upon pulling different points of data from the cost reports information. So, I think those
and
are
interestingly, yeah, go ahead, Tom.
No, go ahead, Barb.
I was just going to say, and when we did a detailed dive and looked at our most expensive providers and looked at the case mix of their residents, we actually found what we didn't expect. We found our most expensive providers were serving the lower case mix patients. So we weren't even getting more toward the people most in need. So there was just a lot of wrong incentives in the system, and it's easy to happen when you get too focused on covering costs.
Thank you. We have a number of committee members with their hands raised, so I'm going to move on to the next question. Dr. Miller, you're up next.
Thank you so much. These are really great presentations. My questions are targeted to Nikki and Wendy in regards to QIPMO. I was wondering if you could tell us a little bit about how QIPMO is financed. And I'm also curious, do you do any consultation with the state surveyors? And then the third area is, how do you track impact of QIPMO over time?
Nikki, do you want to go ahead and take those?
Yeah, I'll take that one. We're financed through civil monetary penalties. We are, we do a 3-year contract through the Department of Health and Senior Services, and the majority of our financing comes from CMP's funds. In regards to surveyors, the survey collaboration, we do provide education for surveyor training. And, during the public health emergency, we the department manager and I, we spoke weekly in regards to what was occurring in the state. And we collaborate with them, on an as need basis. When there's a need that comes up from the state, they're more than happy to reach out and ask us to assist them with that. And then as far as the impact, we track it through, looking at quality measures and what quality measures are improving in the state. And also we always welcome, participant feedback in regards to, how we can better improve our services for them. Wendy, you have anything to add on the impact or surveyor collaboration?
I would just say that a lot of times we do get calls from a home who've recently had a survey and, they found a deficiency, and the surveyors will say, you need to call Quitmo and have them come in and do some education. So we get that call pretty frequently. And as Nikki said, we also measure impact, based on our website in terms of how many people have accessed it and the information that's going out there. And I think also just in terms of, when we do our mock surveys, if we're seeing the same citations and the same problems from the previous year, we're looking at what they were cited for after our surveys, and if they were able to improve, or if they took advice that we gave, particularly in terms of the life safety things and the infection control. You can lead a horse to water, but they don't necessarily have to take that advice. So that's pretty much how we measure our impact.
Thank you.
Dr. Rance, you're up next.
I have two questions, a follow-up for Nikki and Wendy about addressing workforce issues in Missouri and staff turnover in buildings. What kind of approach and strategies and any impact that you've had with workforce and recruitment, retention, helping facilities?
Actually, one of our coaches, Mark, he's just recently developed what he calls a 5-star program, and it's an employee engagement program. So we're very excited to get that kicked off and working in homes. We have some pilot homes that are participating, getting ready to participate next week, actually. And they will be the first homes. But as far as, it's a challenge. It's a challenge everywhere. We see a lot of turnover. We get the director of nursing and the administrator changes usually on a weekly basis. There is a lot of senior leadership turnover in these homes. And of course, you need that stable senior leadership in order to build that rapport amongst your staff in a home. And if that senior leadership is constantly turning over, there's never really any progress, basically, in terms of quality and, getting things set in motion, implementation. It takes a long time to implement something and change.
What about support groups? The targeted support groups.
We do targeted support groups for MDS, training, and Wendy can speak on, she's actually doing some DON trainings right now on targeted support groups. So I'll let Wendy talk about those.
Yeah, so that's one of the areas that we identified as being really, really helpful to administrators and DONs. One of the other team members has actually been doing those DON support group meetings in her area for a while. In my particular area, they're just kind of now getting on board. However, we had, for example, a couple weeks ago, I had 8 different homes represented, and we did a 2.5-hour session in person. And that just allows those directors of nursing to network and have other opportunities to learn the process, learn what the expectations are, and not just be able to call on Quitmo, but be able to call on each other. And that's a really huge thing in this industry because, in smaller towns where a lot of my particular region is in Southeast Missouri, you have staff that just float from one home to the other. And you might be a DON at one home 1 week and at another home 2 weeks from now. So, they have those conversations, and knowing that we're all on the same page and are there to support each other, I think is really helpful in terms of some staff retention, because they don't feel like they're alone. And I think not feeling alone is a really important facet of getting through the regulations and the processes and expectations.
I had a follow-up question also for Barbara. Barbara, you mentioned using Ohio's Resident and Family Satisfaction Survey, and CHAPS also you mentioned. So tell us more about what's going on in your state with those surveys, and how are the data collected, and how often are the data collected and used?
My understanding is that the Department of Aging administers the surveys, and in I may get this wrong, but in even years, they administer, say, the resident satisfaction survey, and in odd years, they do a family. They administer the family survey. So they take turns, and the results of those surveys are then factored into the state's quality incentive payment for the providers, the nursing homes. Which I think is terrific.
Yeah, and so are they using CHAPS, or what other instrument are they using?
I think they're using the CAPS survey instruments. Yeah, and the state also uses CAPS for managed care consumer satisfaction. So I think there's sort of an all-in around using those tools, which helps provide some comparability across the results. But I was really pleased to see that the state was doing both the family survey and the resident survey, and with the Department of Aging administering it, you've got a little bit of an arm's length on that. So I think it's a good strategy. Again, it's not clear to me the state has, it's hard to know if you've got the right amount of money attached to the results of that, or whether or not the bar is set very high in terms of the level of performance before you earn reimbursement under the incentive payment. But that information is being used, and it is being sought from families and residents.
Dr. Galambos, you're up next.
Thank you, everyone, for just very informative presentations. I really appreciate the time and effort that you took to present the information to us. This question is for Tom. Tom, in your write-up, you talk about when you were working in Arizona. Arizona successfully pursued a multi-year strategy to integrate behavioral health services in long-term care facilities. As you know, this is an area that facilities just struggle with in terms of services and in terms of cost. Could you speak a little bit more to that initiative and what made it so successful?
Sure. So more broadly speaking, the effort was around integrating behavioral health with physical health services throughout the Medicaid population. Actually, in Arizona, long-term care was integrated from day one. And, I spoke to some of the disjointed nature that exists within Medicaid structure and for dual eligible members. And oftentimes it's because we have individuals being served by multiple payers. So in some states you have Medicaid serving physical health through an organization, behavioral health through a different organization, long-term services and supports through yet a different organization, and then you layer Medicare on top of that. So just the complexity of having so many different organizations involved in the delivery of care means that there's none. With regards specifically to behavioral health and nursing facilities, I would say that Arizona is still working through some of the challenges for the most complex populations. We have a designation of individuals with serious mental illness. That population is now aging in some instances in which it had not in the past, and being able to have appropriate placements is still an area that I think the state is working through. But it started first with integrating the payer streams, and then there's been further supports provided to providers to think about integration and how we better connect behavioral health and physical health services. There's actually a third-party report that looked at Arizona's efforts specifically around individuals with serious mental illness, and it found that this braiding approach and providing additional support for providers, again, more broadly, not just in the nursing facility setting, resulted in improvement with all ambulatory measures and all CAPS measures. And in 5 of the 10 CAPS measures, the improvement was double digit. So there's some third-party validation of these integration efforts, but it didn't speak specifically to nursing facility. It was more broad in terms of the overarching healthcare delivery system.
Thank you very much.
Yep.
Dr. Grabowski.
Great, thank you. This has been a great session. I really appreciate the perspectives of all the different speakers. My questions, I have 2, are for Tom and Barbara. Both of you mentioned paying for quality or paying for value. I think maybe Marilyn's last part of her question began to get at this, but can you help us think about what are the quality measures, what are the value-based measures you trust the most? What are the ones that you kind of would like to see built into Medicaid payment systems? And then the second part of it is, it really builds off Tamara's earlier question of some of the related party transfers and accountability. We all know the cost reports, you get what you get, and there's a lot of noise in those cost reports, yet there's been a lot of talk and effort about increased accountability and transparency. And I want to get your thoughts on that set of kind of oversight activities and how much you think we can improve the information that's coming. How productive or fruitful would that be? Thanks.
Barb, you want to go first? Okay. I'd like to think some more about the specific measures that states should be rewarding around value. In Arizona, we had a small program. I don't think the measures were great. It was pneumococcal vaccinations and wound care and things like that. But there's more that can be done. Obviously, Medicare has increased its overall number of measure sets. Clearly, consumer satisfaction is another area that Arizona does some rewarding on. The areas that I think we need to be able to continue to get more insight on and measurement and then reward value are things like hospital transitions, because I pointed this out. I think nursing facilities are incentivized to have individuals go into a hospital so that they can get the Medicare reimbursement. And I think there should be opportunities for facilities to be able to get value from being able to serve the individual within their setting and not have to go to the nursing facility, again, where appropriate. But I think too often, facilities defer to a hospital placement because it does provide more incentive on the backside in terms of revenue, and it's complete misaligned incentive. So if there's a way to measure in terms of hospitalization rates and have Medicaid provide some reward for that, that was something we talked to our plans quite a bit about, because we did have nursing facilities come forward and complain about the very fact that once we aligned individuals where they were in the same plan for Medicare and Medicaid, the nursing facilities saw a pretty dramatic drop in the overall use of hospitalization for individuals that were in a nursing facility placement. I think the other is transitions of care back into the community. So many times we see individuals go into a nursing facility and then they're just there. And there's not enough done to get individuals back into the community. And not everybody's going to make the transition back into the community. I recognize that. But I think too often times people go into a nursing facility and they just get stuck. And we haven't rewarded the nursing facilities to come back and look at the full continuum. And I think some of that's on the nursing facilities because, at least in Arizona, I think they maybe have done more of this in other states. They don't offer the full continuum of services, right? They're a traditional nursing facility player. That's where they're comfortable. And they really haven't grown where they're offering a full array of services from, attendant care to supporting individuals in the home all the way to nursing facility. And I think if you saw more divestiture in terms of nursing facilities offering a full continuum, there might be more incentive there as well. Barb?
Well, Tom, I really like where you're going with this because, David, my sense is that with regard to the clinical measures that have been developed, just pick some, right? And I don't think there's some that are, I think the industry and the state together could probably figure out the right place to start. And I know that some states are doing quality improvement plans on a facility basis within their larger quality initiatives. And that's also fine because plans may be in, health providers may be in different places where they need to be working. They may have nailed one thing and not something else. So I think the nationally developed measures are good and they ought to get used, and just pick a couple and go, right? But I do think that where there's not as much attention being are some of the areas Tom talked about. One is behavioral health, and sort of what's the effectiveness of bringing good mental health attention into long-term care facilities. But I strongly agree with needing nursing facilities to be engaged in trying to improve that holistic approach to services for people that are in the nursing home, and not be incentivized to simply dump people back into a hospital or to incentivize to hold on to people, particularly when they're in their Medicare days, in a way that transitions then into a Medicaid long-term care stay after all of the home supports have disappeared. So I do think those are the areas where, if you want to have a system of care that's working, you'd want to incentivize nursing homes to play better in that space. This is part of why some states turn to managed care. They're hoping managed care plans can get in there and figure out how to get nursing homes and other parts of the system to work more effectively together. But they don't have magic bullets. This is something that people need to work, I think, together on, to figure out how you want this system to behave, and then incentivize that behavior. The other thing I want to just mention, and it's not exactly what you asked, but particularly having been a family member of someone who was in a nursing facility, trying to better understand the relationship of nursing facilities and hospice. Because the other place that nursing facilities have a tremendous incentive is to move people into hospice while they're still in the facility, because it brings a lot of additional revenue to bear. It frankly allows the nursing facility, and from my observation, to offload some of what ought to be their responsibility for services and care to the hospice provider. And it seems like it must be creating some very strange incentives in there. And I wonder about whether it is what impact it's had. Now, maybe people who have hospice are getting a better quality of care because there's more people now paying attention to them, but it's not because the facility is doing it. It's because there's this whole other player in the system. And I think there needs to be some more attention paid to what's really going on there. Frankly, I don't understand going forward why we wouldn't want nursing facilities to incorporate hospice approach and philosophies in terms of care for individuals, the communication with individuals and families that you get from hospice that you don't typically get from a nursing facility. There's a lot there just in the way hospice behaves that I think could greatly improve the quality of care for individuals, and it might be worth some attention. Obviously, there's a lot more money coming in when someone gets into both hospice and the NIP.
The question didn't come to us, but just to maybe add one measure that Barb and Tom didn't mention, but one that we track closely in Kansas with our managed care plans, is the inappropriate use of antipsychotics and psychotropics. I think we get regular reporting on that. Our managed care plans are a part of that. It says a lot about the system of care and what's being tracked in nursing facilities. So that would be another, if we're going to just, as a list of measures to pick, that's a good one that looks at a lot of different factors as well.
And paying attention to whether people get sort of blanket diagnosed as having certain psychiatric problems in order to justify that overuse.
Sorry to interject, but I thought it was a good addition.
Yeah, no, thanks.
Assistant Secretary Greenlee.
Hello. I wanted to talk a little more about the two very different populations of residents served in nursing homes. The short-term stay residents, primarily there for Medicare post-acute, the long-term stay residents then would skew very heavily to Medicaid, and just get the group's impression about whether there's anything we should do differently to regulate accounting for those two very different populations. You could have a home with a real high percentage of long-term residents versus a home that really has a low percentage and focuses on Medicare post-acute. Should we make any changes? They've come up contextually today, as we've talked about lack of care coordination and the perverse financial incentives, but should we look differently at the populations from a regulatory perspective in any way? How could we see those two and appropriately kind of respond to their differences?
There's certainly a difference. This is Scott Bruner from Kansas, and just from the regulatory perspective, in Kansas we have a good number of hospitals that work with swing beds, so try to kind of bridge the two settings. Those are regulated by different agencies in our state, and it works, but kind of not probably the ideal way that you would structure something if you were starting from whole cloth. So I don't know about in terms of should the survey process or regulatory process be different, but it certainly is an area that's complicated, and I'm not sure you're getting the best quality of care for folks that are maybe not stuck, but are trying to need that post-acute care, and then what's next, and that isn't as clear of a transition. So, but echo the point that it's complicated, and I don't know the regulatory environment makes it any less complicated.
Yeah, I would hesitate to suggest a strategy that increases the complexity of regulatory oversight for the providers. But I do think that it's entirely possible. If you looked at each business line separately, you might see differences, right, in terms of how a facility would score on its survey results, or how it would, if you looked at the star rating and had a star rating for long-term care and a star rating for post-acute care, whether or not you wouldn't see differences. I think that the staffing issues and the turnover issues, while they're important on the short-term side, just in terms of training and standards and administration, I think on the long-term care side, they absolutely impact quality of life in a really significant way. And I think they are two very different business lines. And I have for a long time wondered why we continue to see an industry that sort of presents them both, and buyers who act as though it's a single provider when really you're dealing with two very different lines of business.
So my answer comes from a different perspective, and it has to do with the payer perspective, particularly on the Medicare side. So we're seeing incredible growth in dual special needs plans. Dual special needs plans, states have the ability to have some regulatory input in terms of what the behavior is for those dual special needs plans. The dual special needs plans are now required to share information with states for certain populations that might be going into an inpatient setting or an emergency department setting. As we're having this conversation, it seems to make good sense that now a dual special needs plan should have to share information on individuals that will be transitioning out of a nursing facility due to a short-term post-acute stay, because oftentimes the types of services that are necessary to support the individual are coming out of the waiver side. And for a fee-for-service state in which the individual is not aligned and in the same plan or the same organization for Medicare and Medicaid, that service support is going to need to come from good transition planning. So states may want to actually consider having some expectations as it relates to dual special needs plans as part of the contract they enter into them with annually in terms of doing more transition planning around individuals leaving that setting.
Thank you all.
Lacey, did you want to make a comment earlier?
I was just going to add a little bit of kind of what Tom touched on kind of how that continuum of care and payment process and how that kind of complicates things from the payee side.
Dr. Stevenson.
Hi, thanks everyone for your presentations. It's great to hear these perspectives on some really challenging issues. I have a couple areas that I would love to hear more from Scott and Lacey about. The two areas in particular are ownership and kind of corporate structure, and also targeted surveys. The first, given the wake of Skyline and what happened with it, I'd love to hear a little bit more about what your agency either does already or would like to have the capacity to do, kind of in terms of looking at owners and the care that they might provide across facilities, or knowing more about them. You mentioned information and technology, on a more timely basis from CMS. I don't know if that's included in what you might like. The second area relates to the Special Focus Facilities Program. There aren't many facilities in Kansas that are in that program. There are a little bit more that are on the, I guess, candidate list. But then also on the flip side, some have proposed kind of expanding that program, but then also having, reduced surveys activities around high performers. And I don't know if you, can comment at all on whether you think that's a terrible idea or a good idea to, basically make resources more efficient. So any comments you have on those two areas would be great.
I'll start on the ownership side. So we do try to, and get lots of questions about, as primarily out of state, but not exclusively out of state owners are looking at buying or adding Kansas properties to their portfolios. And we try to do that. I wouldn't say we're experts at forensic accounting or more of the complex transactional parts of it, but we do require those facilities and those owners to follow Kansas rules and understand what they are. So I think in that sense, they're getting the playing field is fairly level. One of the challenges, though, and I'm a little new in this position, but COVID hit shortly after I started, was that some of the chains wanted to bring their corporate approaches to Kansas, which sometimes were more restrictive than what the state guidelines were for visitation or other things before the CMS set the standard. So I have been curious, and it's one of the topics kind of probably post-COVID to look at is sort of how do we communicate with we spend a lot of time trying to communicate directly to the buildings that we license, the facilities that we license, but I don't think that gets passed on necessarily to the corporate ownership as well. So I think there's almost a stakeholder part to engage that we need to do. But yeah, I think that it is an issue of we're saying you've got to follow the state guidelines, that we'll occasionally get some push about this isn't what we have to do in the other states that we operate in. And I'm pretty comfortable saying I don't really care. This is what our state policy is, and our legislatures identified consistent with the federal rules. So so I feel okay with that, but it's probably a frustration from the other side. But and maybe Lacey has an idea about the special focused facilities, because that's.
Yeah. I do have a few comments if that's okay. So one, I will tell you that, so in Kansas, we were impacted by Skyline to I guess to quantify it, by 15 facilities. So there were 15 facilities in the state of Kansas in which we basically took into an immediate receivership and took over the roles and responsibilities of owning and operating 15 nursing homes overnight, basically. And there has been a lot of discussion around how we can prevent that from ever happening again. And one of the things that we did was we kind of made some very quick reactions, and were able to, in that following legislative year, so come May 2018, we did go ahead and revamp and revise the statutory requirements for a new owner or a change of ownership as far as what paperwork they were to be providing. Prior to that, in the state of Kansas, you had to provide 3 months worth of financials. So 3 months worth of past financials, as well as a 3-month projected financial income and balance sheet. And we did things such as extending that to 12 months, as well as moving and looking into having our financial analysts within our agency be reviewing those financials instead of the licensure staff. The other thing that I would say, I think, as far as what I think would be nice to have, that I don't think that there was a lot of, and things that we could learn from with Skyline, is the ability to collaborate with other states on poor performing owners, not necessarily the facilities, but the poor performing chains. And when they're seeing that, and kind of opening up that communication, and or maybe even being able to figure out a way to designate that on the 5-star review, and grouping people by the facilities they own and not just by individual states, so that a provider or a potential client could see, how they're performing nationwide and not just at one facility within their state. Second part to that question, the special focus facility program. So in Kansas, we are required to have a minimum of 2 states based off of the number of facilities in our state. We only do 2. That is mainly based off of our survey staff and the amount of survey work and backlog we have, as well as the idea that when you're looking at our special focus candidate list, A large number of those candidates tend to be around the northeast area of our state, which coincides with the area of our state that we have the least amount of staff. So we're trying to, on a state level, kind of internalize how we can get all of that work done and still be meeting the standards that CMS has set for us as the state survey agency. To that end, I do know there has been talk of allowing for nursing facilities to become deemed and kind of integrating a deemed status on the back end of a special focus facility program being ramped up. And I do think that there is some value in a discussion around those higher performing homes being able to have that deemed status, and then looking at then that survey and oversight work of the state survey agencies and reshifting that focus and that demand of ours that CMS has.
Thanks very much.
Dr. Travers.
Sure. Thank you, everyone, for your substantive remarks. I wanted to ask Wendy and Nikki what you will see as the possibilities and potentials when it comes to university collaborations. What does that consist of? How does that exchange look like? And then for Tom and Barbara, just thinking about what services and initiatives have you seen that have been addressing social determinants of health, inequities, and disparities in the nursing home space?
Nikki, I don't mind to start on that one. Particularly this year, we've seen a lot of collaboration with the university in terms of infection control practices. You know, they were able to get us things straight from the medical school right away for us to send out to homes. We also were able to work with the university radio. One of our nurses has a connection with a group, I can't remember the name of it, but they produced face shields that we were able to get out to the homes, and we were able to talk about that and get support, some more of that community networking through the university radio. Just a lot of clinical best practices that we are able to fall back on, and then also the Missouri's the telehealth echo through MU. And I don't know, Nikki, if you want to speak more about that, but definitely a lot of good resources for us from the university.
Yeah, thanks, Wendy. We partnered with the Show Me Echo through the AHRQ initiative that began back late last year. So we've been, advisory committee advisors to the committee for that echo that started back in December, and it's still ongoing. Actually, now we're still doing it on a weekly basis, providing, education and information to the homes on a weekly basis.
So I will offer that where I've seen states doing work that was probably most connected with social determinants and challenges really had more to do with helping people leave a nursing facility, particularly under Money Follows the Person and some of the federal grant programs over a large number of years, where states were able to build community capacity to go in and work around an individual who said, I really want to go home. Often folks don't have a home to go home to, right? So one of the biggest challenges that communities have to wrestle with is housing that's safe, accessible, affordable. Because once someone leaves the facility, Medicaid can't pay for that housing in the community. So, but I think we saw some states and some communities get pretty good at helping really individualized solutions for people, really help people find a match in terms of housing. We also saw federal HUD interest during the Obama administration on helping make vouchers available to local housing authorities who were willing to work with their local Medicaid programs to prioritize, particularly people with younger adults with disabilities who needed housing in the community to be able to leave facilities and leave institutions. And I think, again, we saw some good examples of what can come out of that kind of focused collaboration to try to wrap solutions around individuals. But the lack of affordable housing is one of the biggest barriers that we hear over and over again worse in some parts of the country than others, but it's certainly a common theme in terms of that level of social determinants and inequities. Tom, I don't know if you can think of other things that you've seen states doing. I think there was a big fear that the loss of some of those federal would undermine the ability of states to continue to run some of those programs. So there always is interest in, that's really a place where federal money has been very helpful.
I think yes to everything that you've said, Barb. And again, I think some of the states have tried to leverage the managed care platform to continue to push out more services around social determinants. The other thing that I would add is that states are trying to dig more and better understand the Medicare supplemental benefits now that are available around social determinants. So the 14-day post-inpatient food support that can be provided to individuals. And so states are wanting to get information from plans to better understand their supplemental benefits and better understand how the plans are using the flexibility that Medicare is now offering. And I think there's also just a general discussion around where can we continue to push the envelope on the Medicaid side in terms of what might fall under the MLR calculation around social determinants. So, but again, I think a lot of that is to support individuals either in the community already or moving into the community. And not a lot of it is done in terms of supporting individuals that are within an institution, because probably the state is stepping back at that point and saying, you know, we're covering room, board, food, everything else like that. So what else more is there to do from a social determinants perspective in terms of somebody that's in an institution already?
Thank you.
Dr. Alexander.
Hi, thank you very much, everyone. So I have a couple of questions. One that relates to civil monetary penalties. So we've seen a great model here that's using civil monetary penalties to improve quality. As a panel, we've had a lot of discussions around civil monetary penalties and how they're used and the variability in how they're used across states. I just wondered if you all had some comments in regards to what sort of recommendations would you have for how those funds should be used? Should there be some flexibility, or would you vote for more rigid kind of regulations around how those funds should be used to promote quality in these facilities? And then the second question I have is related to David talking a little bit about ownership. I'm also curious about rural facilities. They're in a very unique situation, being in the middle of nowhere half the time, both with and the issues that they have with many of the things we've been talking about are profoundly affected by their location. I wonder if should there be special consideration given to rural facilities, and what should those considerations be in improving quality and the expectations for improved quality?
I'll just state very briefly on the CMP side, right? Oftentimes the legislature has a role in stating where those funds are directed, and there's a federal piece and a state piece, right? So the feds oftentimes want their piece back. So, you know, I think states sort of have to juggle all of those different priorities in terms of how those funds can be used. But I like the idea of being able to target some of those resources towards quality.
I think it's a great idea to do that. I think would also like to have targeted CMPs to help provide people with alternative or help facilitate people leaving facilities. But I think it is a pot of money that ought to be put to good use. Be a pretty good sell on that.
I would add.
I was going to say, go ahead, Lacey.
No, you're fine. You can finish.
I just was going to say the issue of rural facilities. I understand that there are rural and then there are really rural facilities, and I think different. In a state like Ohio, where communities are all really feels, they have very different lifestyles. I mean, all those things, there's still very much a difference between a rural community and urban community. One of the things we hear most often is that, but for the people that are hiring workers, you're typically competing with the same labor market, regardless of whether you're in the rural community or the urban community, because there are good freeways, right, between all of those communities. And so sometimes sometimes payers tend to assume that the staffing costs are lower for rural communities, when in fact they may be just as high or even higher, trying to attract that workforce to make that drive to the rural community, and that there's not necessarily lower costs associated with being out there. It may actually be higher costs. So I do think you have to pay attention to the realities of the different geographic impact of underlying costs. And with regard to other regulations, I don't particularly have an opinion.
I was going to add, for the use of CMP funds, I do think that, if there was a way for CMS to, at a national level, analyze the effectiveness of different CMP programs that throughout the state. So for example, the program that Missouri is using, and then maybe kind of have some more structure around required programs that they have seen effectiveness out of. Because I think that when you get into, so in Kansas, a good example between Kansas and Missouri is the Kansas City area. You have staff, you have facilities who are working on kind of both sides of that state, and to be able to have those same quality services available to them would be very nice to have that consistency. Because while you have that kind of robust program in Missouri, Kansas's does look drastically different. So when you're trying to find that continuum of care for someone who's just trying to stay in the KC area, that could be two different states for that resident. So for that resident and their family to be able to provide on those and rely on those same resources and have that consistency, that would be a nice thing, I think, to see in the future. I think the other thing that I would like to see with the CMP program is that, and I do understand that, the funds are how the funds are generated and why they are used for the facilities that are participating in it. It is directed mainly towards residents while they are in that nursing facility. And much to what Barb had said, there's not much for trying to continue care outside of that facility, or to improve quality of life, to get to a point for a resident to be able to move out of that facility and be able to perform those ADLs on their own. There's not a lot of bandwidth within the program right now to be able to spend funds on that. They really want to see results that drive for residents in the home, not residents as they're leaving the home, and that bandwidth would be nice.
Thank you all.
I just wanted to make one maybe last comment about the rural facilities, and I don't know that it's as much of an answer just as some other things to consider or think about. For the rural, or we call them frontier areas, where the hospital is the primary care location. They're also doing some acute care. They've got post-acute, and probably the county owns all of it and runs the nursing home too. I mean, for those communities, it's not. They don't really. It's one place. It's the county facility or the county hospital that's doing all those things. So they don't see the distinctions as much. They try to shoehorn their delivery system for whatever it is into the existing state rules. One thing's our hospitals, rural hospitals, and we've got a bunch of critical access hospitals in Kansas, more than a lot of other states of an equivalent size. But one initiative they're trying to do along those lines is to become a more integrated facility and designate those critical access hospitals that have a small ER, some acute beds, but they're also the primary care clinic, almost not absorbing, but kind of having a primary care role, like an FQHC level status, kind of all in one place, so that there's enough critical mass of care, people, facility, professionals to actually deliver care for people that live in those rural areas. Long-term care could be part of that continuum as well. I don't hesitate to say we need a special financing mechanism or anything like that, but it is something to think about from an integration perspective of, and kind of to Barb's point too, the people that are drawing into work there, the county, and the pandemics illustrate a lot of these things. The county health nurse is the director of nursing for the county nursing home, who's also part-time. They work shifts in the ER in that critical access hospital. It's all the same, a lot of the same people. To the degree we can make their jobs easier, and then think about what kind of services do we want the people who live in those frontier areas, by choice largely, get this kinds of services that they need to be healthy and productive and well across the lifespan. So didn't mean to make the question more complicated, but I do think it's an integration question as much as a financing question.
Well, I will further complicate it by stating, as you think about rural delivery systems, you also have to think about Indian Health Services and the undercapitalized system that is in terms of serving tribal members in long-term care, and the role of the sovereign nations in terms of their ability to do self-determination through 638, but still a lack of capital to build long-term care infrastructure. And I think sort of the lack of federal investment as well. So, we talked earlier about should the federal government paying 100% nursing facility costs. Clearly, I think that's the case of tribal members. And so, having some better insight into that and looking at what additional financing opportunities exist, I think is incredibly important for that population.
Thank you all. We are almost at the end of our time. I see Dr. Stevenson has his hand raised if you'd like to make a last quick question.
Yeah, sorry to jump in with another question. So this one is for Nikki and Wendy. In terms of the facilities you work with, I'd love to hear a little bit more about how they approach you. I mean, it's obviously voluntary. Is the better quality facilities that are more tuned to it? Have you worked with some of the poor performers as well? And also, I mean, given that your services are free, to the nursing homes themselves, it sounds like. Why do you think some nursing homes still argue that survey agencies should play more of a consultative or quality improvement role?
A lot of times they reach out to us through email, through phone calls, through text. We're available to them, Monday through Friday. I tell my homes for my region, reach out to me anytime. We understand things come up on the weekends or after hours, so we're always willing to help them no matter what the time is. Wendy, you want to add anything there?
I would say that, we reach all the homes, mom and pop owners, the corporates, the county homes. We go to all of them. So our services are across the board. And, as someone made a comment earlier, you can have 6 homes by the same corporate and one of them will listen. But the corporate person might not be interested in hearing what you have to say. So it really varies across the board. And I think that, like Nikki said, we just make ourselves available to them. And in terms of how they reach out to us, it depends on the relationship we have. With some of them, I mean, honestly, we've become very, very good friends. With others, they will call at 10 o'clock at night. Last year, we got calls all hours of the day and the weekend. And, what do we do? This happened. We've got it in our home, whatever. But in terms of the corporates, it's really a matter of if the corporate is on board with Quitmo coming in, in terms of how much we can help them in their quality measures and their survey preparation, and if they're going to be responsive to what the surveyors suggest in terms of us having come in and do education. Does that answer your question?
Yeah, it does. Thank you.
I might have a tiny bit to add to that. So we do not have Quitmo in Kansas, but we do have the contracted QIO that CMS has provided, which in the state of Kansas is the Kansas Foundation for Medical Care. And I think that the feedback I've gotten from them a lot of times in the relationship and conversations I've grown to have with them is that a lot of the relationship that they have with the facility sometimes is derived on whether or not we as the state survey agency have mandated the QIO come in and provide assistance and oversight, or whether or not the facility themselves have chosen to reach out and request that same assistance. I think that alone, I think, is some of the feedback I've received on how that relationship starts.
Thank you so much to all of our speakers. We are almost at the end here, so I will turn it back over to Tracy to close us out.
So we just wanted to thank all of our speakers for taking the time to join us today. Obviously, you've given this committee a lot to think about as we head into our 4th meeting next week. And so also just wanted to remind everyone once again who's watching that please submit your resident, family, or staff experiences, perspectives. We want to make sure we're hearing from folks on the ground in those roles. And again, a reminder that today's session has been recorded and it will be posted to the study webpage. If you have any questions, you can always contact staff through the project website. And thank you.